There are professions where the gap between what people need to hear and what is strictly true creates constant ethical tension, where the impulse to provide comfort and reassurance conflicts with the obligation to communicate accurately about situations that involve genuine uncertainty or risk, where the consequences of either withholding difficult truths or delivering them prematurely can be severe enough that practitioners develop elaborate internal calculus for deciding when honesty serves patient welfare and when it creates unnecessary suffering. Nursing occupies this particularly fraught ethical territory, positioned as it is between the medical authority that belongs primarily to physicians and the intimate daily care that creates deep relationships with patients and families, required to maintain professional boundaries while also providing the emotional support that sick and frightened people desperately need, navigating constantly the question of how much truth to share and how to frame that truth in ways that serve healing rather than creating additional trauma. Ayesha Khan had been working as registered nurse at St. Helena General Hospital for 7 years, had completed her nursing degree at 23 and had spent her entire professional nursing career at St. Helena, had progressed from general medical surgical nursing to her current position in the emergency department where she'd been working for the past 3 years. She was 30 years old, lived alone in small apartment approximately 20 minutes from the hospital, maintained the kind of modest single life that allowed her to be available for the irregular shifts and occasional overtime that emergency nursing required, had built her identity substantially around her professional competence and her reputation among colleagues and patients as someone who combined technical skill with genuine compassionate care. The emergency department at St. Helena was mid-sized facility serving urban population of approximately 200,000 people, handling everything from minor injuries and illnesses that could have been treated in urgent care or primary care settings but that patients brought to the ED either because they lacked access to other care or because they misjudged the severity of their conditions, to genuine medical emergencies involving trauma and cardiac events and strokes and other time-critical conditions that required immediate intervention. The department operated with controlled chaos, constant flow of patients with varying levels of urgency, triage systems designed to ensure the most serious cases received immediate attention while less urgent cases waited, coordination between nurses and physicians and technicians and support staff, all occurring in an environment designed to handle crisis but that also had to accommodate the ordinary difficulties and inefficiencies that characterize any complex institutional system. Ayesha's role in this environment was multifaceted. She performed direct patient care including administering medications and monitoring vital signs and assisting with procedures. She served as communication liaison between patients and families and the physicians who made diagnostic and treatment decisions. She coordinated with other departments including radiology and laboratory services to ensure necessary tests were completed and results were communicated appropriately. She managed the emotional dimensions of emergency care by providing reassurance and explanation to frightened patients and anxious family members who were navigating medical situations they didn't understand and couldn't control. The work was demanding in ways that extended beyond just the physical and cognitive requirements. Emergency nursing required constant switching between different patients with different needs, required maintaining focus and precision when tired or overwhelmed, required managing your own emotional responses to suffering and death and crisis while continuing to function professionally. But it also provided satisfactions that other forms of nursing didn't provide. The immediacy of emergency care meant you often saw dramatic improvements in patients' conditions as treatments took effect. The variety meant you were constantly learning and encountering new situations rather than following repetitive routines. The intensity created bonds with colleagues that were difficult to replicate in less demanding environments. Ayesha had developed over her 7 years of nursing, and particularly over her 3 years in emergency department, a set of practices and principles that guided her approach to the work. She prioritized technical competence, understanding that her ability to help patients depended first on her capacity to perform nursing procedures correctly and to recognize clinical changes that required intervention. She valued clear communication with physicians and other team members, understanding that coordination failures could create serious problems in fast-moving emergency situations. And she emphasized empathetic engagement with patients and families, understanding that medical treatment occurred in context of human fear and suffering that deserved acknowledgement and support even when the primary focus had to be on clinical interventions. But she'd also developed awareness of the tensions inherent in trying to maintain all these priorities simultaneously, of the ways they sometimes conflicted in ways that required choosing which value to prioritize in specific moments. Technical competence sometimes required actions that caused pain or distress, inserting IVs in patients with difficult veins, performing examinations on injured or sensitive areas, administering treatments that had unpleasant side effects. Clear communication sometimes meant delivering information that created anxiety or disappointment, explaining that wait times would be long, that certain desired treatments weren't appropriate, that test results showed concerning findings that required additional investigation. Empathetic engagement sometimes created temptation to soften or delay difficult truths, to provide reassurance that extended beyond what clinical evidence actually supported, to prioritize immediate emotional comfort over accurate information that might be distressing but that people needed to make informed decisions. The incident that would crystallize Ayesha's awareness of these tensions and would force her to confront her own practices around truthfulness and reassurance occurred on a Tuesday evening in late January, during the evening shift that ran from 3 p.m. to 11 p.m., during a period when the emergency department was experiencing higher than typical patient volume due to combination of seasonal flu outbreak and series of weather-related accidents that had occurred during afternoon ice storm. Leo Patel arrived at the emergency department at approximately 6:45 p.m., brought by his parents after bicycle accident that had occurred in the neighborhood park near their home. Leo was 9 years old, had been riding his bicycle on path that had become icy during the afternoon's freezing rain, had lost control on a curve and had fallen, had struck his head on the pavement despite wearing helmet that had probably prevented more serious injury but that hadn't completely protected him from impact. His parents, Rajesh and Priya Patel, were visibly frightened when they arrived, were experiencing the particular terror that parents feel when their child has been injured in ways that might be serious, were struggling to maintain composure while supporting Leo, who was conscious but crying and complaining of headache and dizziness. They'd driven him directly to the hospital rather than calling ambulance, had made the decision based on proximity and on assessment that Leo's condition was serious enough to require immediate medical attention but not so critical that waiting for ambulance made sense. Ayesha was assigned to Leo's care after he'd been triaged as moderate urgency, not the highest priority category that would indicate life-threatening condition requiring immediate intervention, but serious enough to warrant prompt evaluation given his age and the mechanism of injury involving head trauma. She introduced herself to the family with the warm professional manner she'd cultivated, explained that she'd be conducting initial assessment and preparing Leo for examination by the physician, worked to establish rapport with Leo by speaking to him directly rather than just to his parents and by acknowledging his fear and discomfort rather than dismissing them. The initial assessment revealed vital signs that were within normal ranges for his age, heart rate slightly elevated but consistent with pain and anxiety, blood pressure normal, respiratory rate normal, oxygen saturation excellent. Leo was alert and oriented, could answer questions appropriately, could follow commands like squeezing Ayesha's hands and moving his extremities, showed no obvious signs of neurological impairment beyond the headache and dizziness he was reporting. The helmet he'd been wearing showed significant impact damage on the left side, suggesting that the fall had been serious enough to potentially cause injury even with the helmet's protection. Based on the mechanism of injury and Leo's symptoms, Ayesha knew the standard protocol would include head CT scan to rule out intracranial bleeding or other serious injury, would include monitoring for any changes in his condition that might indicate evolving complications, would probably result in observation period even if imaging showed no acute problems given that some head injuries manifest delayed symptoms. She explained this plan to Leo's parents, obtained consent for the CT scan, began the process of preparing Leo for transport to radiology. The preparation involved completing various documentation, consent forms, nursing assessment notes, orders from the physician who'd briefly examined Leo and had confirmed the plan for CT imaging. The documentation was routine but time-consuming, required careful attention to ensure all necessary information was recorded accurately and that proper procedures were followed for pediatric patient undergoing imaging study. It was during this documentation process that Ayesha made the error that would create the subsequent moral crisis. She'd completed the CT scan order form, had sent it to radiology through the hospital's electronic system, had assumed based on the system's confirmation message that the order had been properly received and that radiology would be preparing to receive Leo for the scan. But what she hadn't noticed, what the system's interface design made easy to miss, was that the order had been flagged for additional verification because Leo's insurance information hadn't been fully entered into his patient record, that the flag meant the order was in pending status rather than active status, That radiology wouldn't actually receive notification about Leo's scan until the insurance verification was completed. The error wasn't uncommon. The hospital's electronic ordering system had various verification requirements that sometimes created delays. The insurance verification process was supposed to be handled by registration staff but sometimes fell through the cracks during busy periods. Experienced nurses had learned to double-check that orders had actually been received by other departments rather than just assuming system confirmations meant successful transmission. But Ayesha had been working on insufficient sleep after covering colleagues' shift the previous evening, was managing multiple patients simultaneously during the busy evening, was operating with slightly degraded attention to detail that made the kind of verification she'd normally perform feel like additional burden she didn't have capacity for in the moment. Approximately 40 minutes after Ayesha had submitted the CT scan order, while Leo was resting in his examination room with his parents sitting beside his bed asking periodic questions about when the scan would happen and what the results might show, Rajesh Patel approached Ayesha at the nurse's station with expression of increasing anxiety. "Excuse me, Nurse Khan, I'm sorry to bother you, but we've been waiting for quite a while and no one has come to take Leo for his scan yet. Is everything alright? Should we be worried that they're taking so long?" The question was reasonable. 40 minutes was longer than typical wait for emergency CT scan on pediatric patient with potential head injury, was long enough that concerned parent would naturally wonder whether the delay indicated some problem or whether it was just normal variation in hospital processes. Ayesha's first response should have been to check on the order status, to verify that radiology had received the request and to get information about expected timing for the scan. But Ayesha was in the middle of managing crisis with different patient, elderly woman who was experiencing cardiac symptoms that required immediate attention, who Ayesha was monitoring closely while waiting for physician to complete examination and make decisions about treatment. The interruption from Rajesh, though completely understandable from his perspective, was coming at moment when Ayesha's attention was divided and when taking time to properly investigate Leo's scan status would mean stepping away from the cardiac patient whose condition was more immediately serious. So instead of being honest about not knowing why the delay was occurring, Ayesha made quick decision to provide reassurance that would address Rajesh's immediate anxiety without requiring her to actually investigate the situation. "Everything is fine, Mr. Patel," she said with confident smile that was meant to project competence and control. "The radiology department is very busy tonight. We've had multiple trauma cases come in during the past hour and they're working through their queue. Leo's scan is scheduled and they'll call for him as soon as they have a scanner available. His vital signs continue to look good and he's stable, so while I know the waiting is difficult, there's no indication of any urgent problem that would change our approach." The reassurance was partially true. Radiology was indeed busy, Leo's vital signs were stable, there was no immediate indication of serious problem. But the core claim, that Leo's scan was scheduled and would happen as soon as radiology had availability, was false. Ayesha didn't actually know whether the scan was scheduled, hadn't verified the order status, was making assumption that turned out to be incorrect because the order was still in pending status waiting for insurance verification. Rajesh accepted the explanation with visible relief, returned to Leo's room to update his wife, and Ayesha returned her attention to the cardiac patient whose situation required immediate focus. The exchange had taken perhaps 90 seconds, had accomplished its immediate purpose of addressing Rajesh's anxiety without requiring Ayesha to divert attention from more urgent clinical situation, had allowed her to continue managing her multiple responsibilities without disruption. But even as Ayesha refocused on the cardiac patient, even as she successfully managed that situation and helped stabilize the woman's condition, there was small uncomfortable awareness beginning to form, recognition that she'd provided false information to concerned parent, that the reassurance she'd offered wasn't based on actual knowledge but on assumption, that if the assumption turned out to be wrong the consequences could be serious. It was another 30 minutes. Now more than an hour since the original CT order had been submitted, before the radiology technician who'd come to the emergency department to pick up different patient happened to mention to Ayesha that they hadn't received any orders for pediatric head CT that evening, that their schedule showed no pending scans for anyone named Patel. The information created immediate alarm. Ayesha quickly checked the ordering system, discovered the pending status and the insurance verification flag, realized that Leo's scan hadn't been scheduled at all and that her reassurance to his parents had been based on false assumption. She immediately contacted the registration staff to complete the insurance verification, pushed through the order once the verification was resolved, confirmed with radiology that Leo could be scanned within the next 20 minutes now that the order was properly active. But the resolution of the practical problem didn't resolve the moral problem that had been created. Ayesha had told Leo's parents that everything was fine and that the delay was just normal queue management, when in reality the delay had been result of error that she hadn't detected and hadn't verified before offering reassurance. The lie hadn't been malicious, hadn't been intended to deceive or to cover up negligence, had been motivated by genuine desire to reduce the parents' anxiety and by practical need to manage multiple competing demands on her attention during busy shift. But motivation didn't change the fact that she'd provided false information to people who were trusting her professional expertise and who were depending on her to give them accurate information about their son's care. The deception had been small, had involved relatively brief delay in imaging study rather than any immediate threat to Leo's safety given that his condition remained stable. But the deception had violated principles that Ayesha considered fundamental to ethical nursing practice: honesty with patients and families, verification of information before communicating it as fact, acknowledgement of uncertainty rather than false confidence when actual knowledge was lacking. When the radiology technician came to transport Leo for his scan, Ayesha accompanied them to Leo's room to explain to his parents what was happening. Rajesh and Priya thanked her for the update, expressed relief that the scan would finally be done, showed no awareness that there had been any problem beyond normal busy hospital delay. Ayesha could have left the interaction there, could have allowed them to continue believing the reassuring explanation she'd provided earlier, could have avoided the uncomfortable conversation that acknowledging the error would require. But the discomfort she was feeling about the deception was intensifying rather than dissipating, was creating internal pressure that felt increasingly incompatible with just moving forward without acknowledgement. She found herself speaking before she'd fully decided to speak, found herself offering honesty that she'd initially avoided. Mr. and Mrs. Patel, I need to apologize. Earlier when you asked about the delay, I told you everything was fine and that radiology was just busy. That wasn't entirely accurate. There was actually a problem with how Leo's scan was ordered. The system flagged it for insurance verification and I didn't catch that the order wasn't actually active. That's why the delay was longer than it should have been. I should have checked the order status before reassuring you, and I should have been honest about not knowing the cause of the delay rather than making assumptions. I'm sorry for providing incomplete information. The apology was brief, didn't elaborate on her reasoning or her competing demands, just acknowledged the deception and took responsibility for it. Rajesh and Priya looked surprised. Their expressions suggested they hadn't been particularly concerned about the delay and weren't sure why Ayesha was apologizing for what seemed to them like minor administrative issue. But they accepted the apology graciously, thanked her for her honesty, refocused their attention on Leo who was being prepared for transport to radiology. Leo's CT scan was completed without incident, showed no evidence of intracranial bleeding or skull fracture or other serious injury. Confirmed that his fall had resulted in concussion but not in damage requiring surgical intervention or intensive monitoring. He was observed in the emergency department for several more hours to ensure his symptoms weren't worsening, was eventually discharged to his parents' care with instructions about monitoring for delayed symptoms and about when to return if concerning changes occurred. The clinical outcome was good. Leo would recover fully from his concussion, the delayed imaging hadn't resulted in any harm, the error in order processing and Ayesha's subsequent deception hadn't created any lasting consequences for the patient or his family. From external perspective, the incident was minor deviation from ideal practice that had been successfully resolved without negative impact, was the kind of small imperfection that occurs routinely in complex medical systems and that doesn't rise to level of serious error requiring formal investigation or remediation. But for Ayesha, the incident's impact extended beyond just its clinical consequences. The experience had revealed something about her own practices and assumptions that she found troubling, had made explicit tensions that she'd previously managed without fully examining, had forced her to confront questions about truth-telling and reassurance that she'd been navigating intuitively but that now required more conscious consideration. The specific question the incident had raised was, when is providing reassurance based on assumption rather than verified knowledge acceptable, and when does it cross line into deception that violates obligations to patients and families? Ayesha had provided reassurance to Leo's parents partly because she'd assumed the information was accurate, had believed based on her normal experience that submitted orders were processed promptly, had not had reason to suspect that this particular order was experiencing unusual delay. But she'd also provided reassurance without verification because verifying would have been inconvenient, would have required interrupting her attention to more urgent patient, would have taken time she didn't feel she had during busy shift. The convenience factor was what made the deception feel ethically troubling rather than just being honest mistake. If she'd genuinely believed her reassurance was accurate and had simply been wrong due to circumstances she couldn't have anticipated, that would have been unfortunate but wouldn't have involved moral failing. But she'd provided reassurance without knowing whether it was accurate, had chosen to offer confident explanation rather than acknowledging uncertainty, had prioritized managing the parents' anxiety and managing her own time over ensuring the information she was providing was actually true. That prioritization revealed pattern in her practice that Ayesha began recognizing as she reflected on the incident over the following days and weeks. She realized she'd been regularly offering reassurance to patients and families based on assumptions rather than verified knowledge, telling people their test results would be available soon without actually checking expected timing, telling people their symptoms were probably nothing serious before physicians had completed examinations, telling people that delays were normal and nothing to worry about without investigating whether specific delays indicated actual problems. The reassurances had generally been accurate. Most test results did arrive promptly, most concerning symptoms did turn out to be minor issues, most delays were just routine variations rather than indicators of serious problems. But the accuracy of outcomes didn't change the fact that Ayesha had been communicating assumptions as facts, had been providing false certainty when honest acknowledgement of uncertainty would have been more appropriate, had been prioritizing short-term comfort over truthfulness in ways that violated principles she considered fundamental to ethical practice. The recognition of this pattern led Ayesha to modify her communication practices in subtle but significant ways. She became more careful about distinguishing between what she actually knew and what she was assuming, became more willing to acknowledge uncertainty rather than offering confident reassurance that extended beyond verified information, became more diligent about checking facts before presenting them to patients and families as established truth. The modifications created some difficulties. Acknowledging uncertainty sometimes increased rather than decreased patient and family anxiety. People wanted confident reassurance that everything would be fine, wanted providers who projected control and knowledge rather than admitting gaps in information or unclear timelines. Some patients and families responded to Ayesha's more careful truth-telling with frustration or with requests to speak with different nurse who could give them clearer answers, with complaints that she was being evasive or unhelpful by not providing the definitive information they were seeking. Ayesha had to navigate these responses, had to learn to distinguish between appropriate acknowledgement of uncertainty and excessive hedging that prevented her from providing useful guidance, had to develop ways of being honest about limitations while still offering appropriate reassurance about what was actually known. The navigation was difficult, required more conscious attention than her previous intuitive approach had required, sometimes felt like it was creating additional emotional burden for already stressed families who might have been better served by confident reassurance even if that reassurance wasn't fully verified. But Ayesha maintained the commitment to modified practice despite these difficulties, maintained it because the alternative, returning to pattern of offering unverified reassurance, felt incompatible with the professional integrity she wanted to maintain. The commitment was tested repeatedly during the months following the incident with Leo, was tested especially during high-stress situations where frightened families were demanding reassurance that Ayesha couldn't honestly provide, where the temptation to offer comforting false certainty was strong because the immediate benefits of reducing anxiety felt more tangible than the abstract principles about truth-telling. There was one particular situation approximately 2 months after the incident with Leo that crystallized the stakes. Ayesha was caring for a teenage patient who'd been in serious car accident, whose parents were desperately asking whether their daughter would survive, whether she would recover fully, whether the injuries would create permanent disabilities. Ayesha's honest answer was that these questions couldn't be answered definitively in the immediate aftermath, that survival depended on how the patient responded to treatment over the next hours and days, that recovery outcomes depended on factors that wouldn't be clear for weeks or months. That some uncertainty was inherent in serious trauma care and that providing false certainty wouldn't serve the family's long-term interests even if it might provide short-term comfort, delivering that honest Acknowledgement of uncertainty to parents who were experiencing worst crisis of their lives was extraordinarily difficult, required Ayesha to maintain professional composure while witnessing their anguish, required resisting the strong impulse to offer reassurance that would reduce their suffering even if that reassurance couldn't be substantiated. But she maintained the honesty, provided what information she could verify while acknowledging what remained unknown, supported the family through their uncertainty rather than trying to eliminate uncertainty through false confidence. The patient eventually survived and made good recovery, though the process took months and involved complications that the immediate post-accident assessment couldn't have predicted. The parents later thanked Ayesha for her honest communication during the initial crisis, mentioned that they'd appreciated being treated as adults who could handle difficult truths rather than being given false reassurance that would have made subsequent complications feel like betrayals of trust. The thanks validated Ayesha's approach but didn't eliminate the ongoing difficulty of maintaining truthfulness when lies would be easier and more immediately comforting. 3 years after the incident with Leo Patel, Ayesha remained working in St. Helena's emergency department, had been promoted to charge nurse role that involved coordinating nursing staff and managing department operations in addition to providing direct patient care. The promotion reflected recognition of her clinical competence and her leadership capabilities, acknowledged the respect she'd earned from colleagues through years of reliable professional practice. But the promotion also created new opportunities to influence how other nurses approached the ethical tensions around truth-telling and reassurance that Ayesha had been navigating since the incident with Leo. She found herself mentoring newer nurses, found herself observing how they communicated with patients and families, found herself sometimes intervening when she heard them offering reassurance that extended beyond verified knowledge or that provided false certainty about inherently uncertain outcomes. The interventions were delicate. Ayesha didn't want to undermine nurses' relationships with their patients or to project judgmental superiority about practices she'd herself struggled with. But she did want to create awareness of the ethical stakes involved in how nurses communicated uncertainty and reassurance, did want to encourage practices that prioritized truthfulness even when truthfulness was more difficult than comforting deception. She sometimes used the incident with Leo as teaching example, would describe her own error and her subsequent commitment to modified practice, would acknowledge the ongoing difficulty of maintaining truthfulness while also providing appropriate emotional support. The self-disclosure was unusual in nursing culture that often emphasized projecting competence and avoiding admission of errors or uncertainties, but Ayesha found that sharing her own struggles made the ethical principles feel more accessible than abstract lectures about honesty would have made them. The teaching was imperfect, couldn't eliminate the tensions that were inherent in emergency nursing where frightened people demanded reassurance that couldn't always be honestly provided, couldn't prevent other nurses from making same choices Ayesha had made to offer unverified reassurance when verification felt impractical or when immediate comfort seemed more important than long-term truthfulness. But the teaching did create more conscious awareness of these tensions, did make explicit the ethical questions that nurses were navigating constantly whether or not they were reflecting on them deliberately. Ayesha never learned whether Leo Patel remembered his emergency department visit or whether the incident had any lasting impact on him or his family beyond the immediate treatment of his concussion. She occasionally thought about him when she encountered similar pediatric head injury cases, wondered whether he'd recovered fully from his concussion, whether he'd returned to bicycle riding without lasting fear from the accident. But mostly the significance of the incident was internal to Ayesha rather than being about Leo specifically, was about what the experience had revealed about her own practices and what changes it had motivated in how she approached the constant ethical negotiations that emergency nursing required. The changes were subtle, wouldn't be visible to external observers, consisted primarily of internal discipline about verifying information before presenting it as fact and about acknowledging uncertainty rather than offering false confidence. But the changes felt significant to Ayesha, felt like they'd made her practice more aligned with principles she considered fundamental even when maintaining that alignment was difficult and even when the practical benefits weren't always obvious. Honesty isn't always easy, but it's essential, especially when others' lives depend on it. The temptation to provide comforting reassurance when honest acknowledgement of uncertainty would be more appropriate is strong and constant, particularly in contexts like healthcare where people are frightened and vulnerable and desperately want to believe that authorities have everything under control and that positive outcomes are assured. But yielding to that temptation creates deceptions that undermine trust even when they're motivated by compassion, that establish patterns where convenience or emotional comfort are prioritized over truthfulness in ways that can eventually create serious harm. Ayesha's story illustrates these dynamics in specific nursing context, but the underlying principles extend to any situation where people in positions of authority or expertise are communicating with others who are depending on them for accurate information. Whether you're healthcare provider like Ayesha, or teacher, or parent, or professional advisor of any kind, any role that involves helping others navigate situations they don't fully understand creates similar tensions between providing reassurance and acknowledging uncertainty, between offering comfortable falsehoods and delivering uncomfortable truths. The resolution isn't simple rule that honesty always takes precedence regardless of circumstances. There are situations where withholding difficult information or framing it carefully serves legitimate purposes, where brutal honesty would create harm that more measured communication would avoid. But the resolution does require conscious attention to when you're offering reassurance based on verified knowledge versus when you're making assumptions, does require acknowledging uncertainty rather than presenting assumptions as facts, does require resisting the convenience of false confidence when honest acknowledgement of limitation would be more appropriate even if more difficult. So stand firm in commitment to truthfulness even when lies would be easier. Act with integrity even when situational pressures create strong incentives to compromise. Embrace difficult truths rather than avoiding them through comforting deceptions. Verify information before presenting it as fact. Acknowledge uncertainty when certainty isn't actually available. Trust that people you're serving can handle honesty better than they can handle discovering they've been deceived even when deception was well-intentioned. The practice is difficult, will create discomfort for you and for people you're trying to help, won't always produce obviously better outcomes than convenient deceptions would produce. But the practice maintains integrity that's necessary for sustained trust, that prevents accumulated small deceptions from eroding the foundations of professional relationships, that honors other people's right to accurate information they need to make their own decisions even when that information is frightening or uncertain. Stand firm, act with integrity, and embrace difficult truths. Honesty isn't always easy, but it's essential. Be StoryWise.